Hello, everybody. I am very honored to have as my guest today Dr. Christine Courtois, uh, well known, I'm sure, to most, if not all of you, as one of the pioneers in the trauma field, whose book, Healing the Incest Wound, was published when, Chris?
It was originally published in 88, and then the second edition was published in 2010.
Right. So that, you know, 87 makes you a pioneer
Yes,
because because no one except you and what Judith Herman were
right.
publishing on on the issue of trauma, period, much less incest.
Hmm.
And Christine has gone on to be an internationally known speaker, teacher, writer. I'm particularly interested in talking with her about one of her newer books on sexual boundary violations by therapists, something we don't talk about enough. Um, and and she is the co-author of what will be the third edition of Treating Complex
No,
Post-Traumatic.
the second edition.
What's the second?
Yes.
Oh,
Oh,
okay. I thought this was
no, this is a different book. We get the titles mixed up. This is our co-authored book that is, I call it the therapist companion for going along and learning about the sequence and the different issues that come up in treatment.
okay. But
Sorry. Yes,
co-
our other book came out in a second edition. Um,
okay.
so but they have similar titles, so it gets confusing.
It gets very confusing. But look for Christine Courtois and Julian Ford because they write so well and they're authors. It's an edited book, I assume.
Yes, to which you have contributed
Yes, I have a
on,
couple of
on,
times.
ex on experiential learning and on sensory modal psychotherapy.
Yes. So we go back. We don't go back to 1987, but we go back to,
Mhm.
I think,
Right.
if I remember, like 1999.
Probably somewhere along those lines.
Right, right. And I had just heard you speak. Um, I think we were at a ISTSS conference. Um, I can't tell you where it was. I think it could have been in Florida.
Mhm.
And and I had just heard you say, remembering is not recovering. And I was jubilant. It's like
Mhm.
somebody is finally saying, remembering is not recovering.
Mhm.
And so then a day or two later, I was about to give my first professional presentation with Bessel van der Kolk, and you walked into the room and sat down. And, and, and I panicked. I thought, oh my God, I'm going to be speaking in front of Chris Courtois. I better not mess this up. But but then I realized that I was inspired by your presence because you were saying remembering is not recovering. And and so when I thought about just drawing on that strength, but then I felt comfortable.
That's good. Good. I think we all react in the same way, by the way, because I've had the same reaction to you.
Really? Wow. It's wonderful um, how, you know, we've done so many years of talking in front of audiences.
Mhm.
Um, and I don't get nervous anymore, except if there's someone like Bessel van der Kolk in the audience.
Mhm.
Um, because, because even though I've known him for 50 years, I know he is very, he's, I don't want to say critical, um, but he's very particular. And if
Yes.
he doesn't like what you've said, he'll let you know.
Yeah, exactly. I have had the same response and the same reaction.
Yeah. So you have, you obviously continue to be passionate about this work,
Absolutely. Very much so.
even though you've retired from practice.
Yes. But I'm still writing and I hope to get back to some training opportunities. I've done some this year. Most recently at the conference, Bessel's conference where you were,
Right, I
because
know.
yeah, because one of the things that I've recently completed also after years of effort is the treatment guidelines that were co-published by the APA and by the ISSTD, Trauma and Dissociation, the guidelines on the treatment of complex trauma. So we presented on that at the conference, and I do want to tell people that it's an important document concerning complex trauma treatment. It's a professional practice guideline. It's not based on the uh, clinical research literature. Of course, we pay attention to it, but it's not based on that. And again, it provides guidance and recommendations for what to do and things not to do as we treat this population.
That's great. And it's especially important that the APA have those guidelines.
Well, one of the things that I would also like to mention is the APA now has 7 sets of treatment guidelines that are devoted to different aspects of trauma. And 4 of them actually came online last year. So there is now, if you go into the practice section of the APA website, you can get all of these guidelines and they're printable. They're in little booklets, so they're very nice. I like things that are organized.
Yeah,
Um, and they range from competencies for working with trauma to clinical practice guidelines based on the research literature to key considerations for all kinds of trauma. There's one for assessment of trauma, and there's the one that we just did on the complex trauma. So it's very
cool.
exciting. This is a Division 56 undertaking, and we've been very successful, although this has been a very time-consuming,
Yeah,
it's been over the course of the last 15 years that all of this work has been done.
yeah. And it's so important because there was a time when the APA, the American Psychological Association, had a very narrow view of
To
trauma
say
and trauma treatment, to say the least.
to say the least. Well, another way that I served was in 1992, and I think this is probably the reference for your remembering my quote. In 1992, I was a member of the APA appointed task force on investigation and memories of childhood trauma. And that was just so contentious. There were 3 of us clinicians working with complex trauma and 3 cognitive psychologists, and we locked horns immediately. And it was one of my more miserable professional experiences. But we did come out with some guidance to help people, and one of them is that um, you know remembering is not recovery.
Yay.
And
So
remembering
true
can
today.
and remembering can happen in many different ways. And you're absolutely right. There had been no work done on memory for traumatic or non-normal event circumstances, and that has changed, which is exciting.
That is exciting. Yes, I know. I've, I'm always so grateful when I see new studies
Hmm.
on,
Yeah.
on
Hmm.
the nature of memory
Hmm.
and how it's processed.
Yes.
Yeah. So tell me about this work on sexual boundary violations by therapists, something that we think about when we have clients who have had their therapists violate their boundaries. Um, but it's not something that therapists talk about as a professional collegial group.
Not nearly enough.
Not nearly enough.
You're absolutely right. And we talk about it if it happens, we shun the individual or we stigmatize them, or the whole circumstance is so shocking that, we revert to silence, which is not the best way to handle it for sure. And I'm sorry to say, Janina, but I've had several experiences in the course of my career where, in one case, an intern, in another case, two of my best clinicians in my hospital practice, and subsequently, one of my associates got sexually involved with patients. And it had profound impact on me, on my staff at the hospital. The betrayal that we felt was acute, not much less what was going on with the patients, and we felt very, very let down. And one of the cases led to a lawsuit, which we successfully defended against and settled. But it was just a terrifying and awful experience, and it completely outraged me, which is why I was interested in doing a book on the topic.
Yeah.
And um, also, in my hospital program, we had taken enormously great pains in our hiring and in our training to talk about boundaries, boundary crossings, boundary violations, the damage done. And I was very, very outraged to have clients who had come to us for treatment of their sexual trauma be sexually re-victimized. So if you're hearing all kinds of outrage, that hasn't gone away. And
Yes.
that was the foundation of the book. And then Judy Alpert, who you might know, who's also a traumatologist in New York City, and Lou Steinberg, a colleague who's very active in Division 39 at APA, they had co-edited a journal, I think it was of psychoanalytic psychotherapy, on the topic, and they were getting ready to put in a book proposal, and they invited me to join them, which I did immediately,
Yes.
and gratefully. And I think we wrote a pretty good book on, it's an edited book, but we covered a lot of bases in what we talked about.
And these staff members and interns were people that you would never have thought.
No, one of them was a very, very sophisticated pre-licensure person who had been recommended to us with no reservations as an exceptional clinician, which she was. I appreciated that about her. And the second person had been an intern, a social work intern with us, and became our director of social work. And this experience where they happened back to back, but the social worker had seen the fallout from the first situation, and it happened anyway. So to say that I was surprised the first time was, you know,
Yeah.
the shock of the second time, and it was the second occasion that led to the lawsuit.
Oh. And is there anything in retrospect about either of those clinicians that would have made you think, oh, this is why they were vulnerable?
Yes, I've given that a lot of thought and consideration, and it turns out they both had histories of trauma, their own trauma that had been maybe worked on but not processed. In both these cases, it went against the norm. These were women who got involved with women patients. So, we think typically of the male therapist being the predator. Well, this wasn't the circumstance. And in one case, there was a direct allegation that the patient had offered to teach the therapist how to be a lesbian. So I don't know whether that, held a particular attraction or what it was, but it certainly the boundaries went down. And there was a lot of contempt on the part of the social worker, and this hurt too. Contempt for myself and the owner of our program, both of us directors of the program, that we were just doing this training, and she had to put up with it because she had to wear a mask during mask herself during the training because she had already gotten engaged with the client in question. And
Wow.
neither one of these women had discussed anything about either sexual orientation questions or difficulties. Oh, they both were married also. They had never discussed any of this and never brought up their histories of trauma in their supervision. They kept them very, very quiet. So my recommendation is to get to know as much as you can about your supervisee on a personal basis. And I realize that's a, that's um, a touchy kind of thing to have to ask about, but I think it's very important. And also talking about what are the vulnerabilities that that person might have if they run across someone, and how can they talk about it without shame? And I think that's one of the things we need to address in the field is
Right.
you can have all these feelings, and there's probably not very much wrong with having a feeling or having a sexual um, attraction to someone. The problem is if you act it out
Right.
in this context.
Absolutely.
Mhm.
Absolutely. And I once heard, probably 20 years ago, a talk by Fran Gavelber, who was, I'm sure she's retired, a social worker in the Boston area,
Uh-huh.
on this topic. And she had a very interesting theory. She said it takes it takes a lot of permeability to really empathize with clients.
Hmm.
So, so our very best therapists
Hmm.
who who have that ability to connect with clients,
Hmm.
ironically, are the most vulnerable
Right.
because the permeability they need for empathy can become too
Hmm.
permeable
Right.
and the boundaries can be lost.
Right. And I'll follow that up with a conversation that I had or a training that I went to by Gary Schoner, who developed and directed the walk-in counseling center in Minneapolis for these very situations. And he was talking about supervision and that it's the therapists that we trust the most at times who are most vulnerable. And if because we trust them, we come to trust them, we become lax in our supervision, that may be part of the difficulty as well. So his guidance was to be continuously monitoring for places where there might be crossings to start with or
Mhm.
vulnerabilities and to bring them to the table in supervision.
Right, right. But there's the tricky thing. It has to be, in a supervisory capacity where the supervisor has power over the therapist.
Hmm.
So when you're an intern or trainee,
Hmm.
um, right, your supervisor is going to essentially evaluate you and your
Hmm.
readiness to be a therapist. And in that situation, it's
Hmm.
very hard.
Hmm.
It's very hard to be as as
Yes.
open as you
Hmm.
need to be.
Hmm. Absolutely.
So, and I remember having a supervisor who was assigned to me as a postdoctoral fellow in Judith Herman's clinic. Judy Herman thought that I was too maternal with my clients, that I wasn't challenging them enough. I was too permissive. So
Hmm.
she assigned me a supervisor whose job it was to sort of scare me straight,
Yeah.
which actually, if the supervisor knew me, probably um, it would she would have known that it wouldn't work because because I'm usually pretty able to collaborate with people.
Hmm.
But if you're trying to force me,
Hmm.
I dig my heels in.
Hmm. Doesn't work so
It
well.
doesn't work so well. And and it doesn't work so well when your supervisor is hyper vigilant rather than
Hmm.
interested
Yeah.
in your case
Yeah.
and what you're
Yeah.
bringing to it.
Yeah. Yeah. And I think it has to be collaborative. And, one of the things that I've learned along the way is to begin supervision with a very open-ended conversation about what's involved and what are the responsibilities. And where I get very tight myself and rigid is to let people that I'm supervising know that they're putting my license on the line,
Right.
because I'm taking responsibility for their cases. And so that means something. And so we have to, that's what I mean about the fine line and balancing things,
Right.
that they owe a duty to us as well as to the client, as we owe a duty to them. Now, I had another situation where an intern entered my private practice, being in a relationship with a previous client. And in her case, her supervisor had been enormously lax in her training. Um, and just never met. So she was out there practicing with a very difficult individual who was very needy, and the boundary slipped. We have there's co-responsibilities everywhere, right?
That's right. That is right. Oh, yes. And, um, I think because it hasn't been something we've talked about. Um, it's one of those subjects that that therapists don't discuss with each other.
Hmm.
Um, it's really hard to share the boundary challenges for
Hmm.
the therapist
Hmm.
because because obviously, um, if we are porous enough to be empathic, we're going to have times where we want to do too much for the client. And
Hmm.
that's where I see therapists getting hooked. Because of my work with DID, I've had a lot of therapists come for help around boundary issues
Hmm.
with DID clients.
Right.
And and I could completely empathize because those child parts would win my heart. I would feel maternal. I would want to
Hmm.
meet their needs. And
Hmm.
of course, often their needs were, their needs were for the mother they never had. Their needs were not
Hmm.
to have me
Right. But
reparent them.
right, right. But their needs were out of the bounds of the psychotherapy.
Exactly.
Mm.
And very luckily, I had a bad experience with meeting too many needs of a client who had warned me. She said, I'm going to call you 100 times. And it's very important that you not always call back. because because I know myself, I'm going to get needier and needier and needier,
Mhm.
and I need you to hold the line.
Mhm.
And like at that point, that was even before I was licensed, I think, or maybe I was just newly licensed. And and I couldn't hold that line because
Mhm.
she would call and say, I want to kill myself. I'm
Mhm.
overwhelmed. And I would feel that this is irresponsible not to stay on the line
Mhm.
until she calms down.
Mhm.
But she was also right because she got worse and worse rather than better.
Mhm. Yep.
And finally, I got a consult from Jim Chu, who I'm sure you know,
Yep.
uh, very, very expert in the treatment of DID, who basically said, um, he said to me, can you tolerate losing her?
Mhm.
Which is a really good boundary question,
Mhm. Mhm.
right? And I said, I can tolerate losing her in a
Mhm.
heartbeat. And he said, okay, then here's what you need to do. You need to reset the boundaries.
Mhm.
And then you have to stick to them like glue. And she will be furious. And she will feel betrayed. And she will try. So she's going to pound on those boundaries.
Mhm.
And your job is just to hold the line. And 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 he was absolutely right. It, and but I couldn't have done it without him.
Mhm.
So I think also, um, we need supervisors who have the years, not supervisors who have wisdom, but they have the wisdom of decades of experience.
Mhm. Mhm. Well, it's interesting that you mentioned Jim because I've long considered him to be my mentor. That he didn't know that he was, but I still use his chapter 10 treatment traps in the treatment of trauma, which became my Bible when I was struggling with these issues. And by the way, I think we should say that just about every therapist struggles with these issues and giving too much, doing too much until you learn that there's an underside to that. And so I always quote Jim, who was very um, he talked about his own experience with a suicidal client, where he really overstepped the boundaries. And I refer to Marshall Linehan's mantra, which is reinforce the right thing. And, that with suicidal clients in particular or self-injuring clients, it's got to be their efforts to decide whether they're going to live or die. And they quite inconveniently put it on us. And you know, we take it hook, line, and sinker when we
Right,
should be collaborating and helping them to problem solve a way out of the situation, that's not reliant on us and on the contact with us.
right, right. And I can understand it now in perspective because
Mhm.
they're reliving
Yeah.
the
Yep.
feeling of if I don't get someone to help me, I will die.
Hmm.
And, and so they feel a sense of urgency.
Hmm.
We pick up that sense of urgency
Hmm.
instead of saying, my job is to not be urgent.
Hmm.
My job is to help this client sit with the sense of urgency
Hmm. Yeah.
and and understand. I mean, the way
Hmm.
I work with suicidal clients now is I understand the suicidality as a part. So
Hmm.
I'm asking them to tolerate the suicidal part
Hmm. Hmm.
and that part's insistence that they
Hmm.
die.
Right. And to find out about that agenda, what's that about?
Right, exactly. What's my favorite question? What is the suicidal part worried about if you live?
Hmm.
Eh?
Yep.
And the answers are always so, just illuminate everything.
Hmm. Hmm.
Right?
Yes, and it's much better to have them speak than to act.
Yes,
You know, again,
absolutely.
again, we're talking about the distinction between feeling something and acting on it.
Right. Exactly. Exactly. So, I think one of the things that was challenging for our generation is that we were just discovering trauma and we were learning the hard way how to work with it.
Absolutely. Yep.
Right?
Yep. So one of my soapboxes is the need for extensive trauma education and training, which is still not available. And, it's also been part of the motivation for my writing and teaching, and also for yours, is, why should people have to make the same mistakes that we made when we
Right.
have so much more information? And why should clients have to suffer through that when we can help with what we have learned? And yes, we learned it the hard way. You know,
Yeah.
I can give you a catalog of my mistakes and things that I learned not to do, or to do instead, which I've tried to put in writing and in my training as you have. So yes, it doesn't have to go back to square one. We've come way too far for that.
Right. Way, way too far.
Hmm.
Yes. But it is, I mean, I'm on the same soapbox. I can't believe that the academic world has not caught up enough
Right.
to include at least an elective course on trauma.
Hmm. Yeah.
But, these
Uh-huh.
courses are so, I mean, people write me all the time and say, where's a good graduate school to
Right.
go
Right.
if I'm interested in trauma?
There's very few.
Right.
Few and
Well,
far between. Well, there was a study that was published last year that clinical psych programs, and I don't know about other psych programs, but clinical psych, 5% of the training directors had something about trauma embedded within their coursework or specialized um, components or specialized courses. I mean, this is outrageous. To me, it's unethical.
I,
And at this point, another thing I wanted to mention, Janina, is I'm working with a group of APA psychologists to come up with a specialization in trauma psychology.
oh, great.
And we've been working on that for several years, and we will have our third application go in, hopefully this time to be accepted. And then we'll go to the American Board of Professional Psychology and put it there as well. And that to
Great.
receive that designation, you'd have to have specialized training and meet all the different competencies that have been outlined. So that would help some, but it's certainly not enough. But I think it would recognize that this is a legitimate area of specialization. And, one course, one CE course, one weekend course is not enough. It doesn't give you enough background to do this work.
Right. But at least it, the work should be mentioned. I
Mhm.
think back to
Mhm.
my psychopathology course,
Right.
right? And how can you teach psychopathology without teaching that there is a
Mhm.
very, very high correlation between a diagnosis of schizophrenia and a history of trauma, between borderline personality and a history of
Yeah.
trauma? I mean, it's like
Yeah.
between depression and a history of trauma.
Mhm.
So
Mhm.
how could it not, even at that minimal level, be
Mhm.
introduced?
Mhm. Well, unfortunately, there is still a lot of, and I hope this is changing, but there's still a lot of professors who do not believe in trauma. They do not, they believe that it's been overemphasized. They believe it's the abuse excuse. I don't know what else they believe, but they're too busy or too ignorant or unwilling to acknowledge that background. And exactly what you just said doesn't require a whole new course. It requires modification in the course to talk about the connection and the correlations that have been certainly understood and reinforced in the last 50 years
Right, right.
and still growing.
It's still growing, still growing. Yeah, received an email from a social worker who is teaching a trauma course in a social work program in connected to, I think it's the University of Arizona. And so first of all, good for her that she got that course
Mhm.
into the
Mhm.
curriculum. And she asked me if I would be a a guest speaker in her course. And I said yes. I think all of us would. I mean, everybody I know who is a leader in this field is passionate about the need for
Mhm. Mhm.
for education on trauma.
Mhm. Yep.
And and I'm sure we would all want to pitch in.
Mhm. Mhm. Yep. But I
Yeah.
think we have to get the major organizations and society behind it. I mean, society also knows so much more about trauma now than 50 years ago, and still doesn't understand it very much because I think the social view is it only happens to people, who men and women who are warriors and who go into combat. But we talk a lot about all of these other traumas, but we don't talk about what happens in the aftermath. Yeah, you can be just, exposed to a weather disaster, but what happens in the consequence? The disaster itself may have been traumatic, but that may have been like the tip of the iceberg for what people go through. And, then they think they're crazy because they have symptoms that they don't connect with what happened to them.
Right, right, right. And if we could just make those simple connections.
Mm, yeah.
Yeah. Yes, well, at least we're not running out of work to do.
That's that's for sure. That's for sure. A lot of work has been done, but it's the foundation because there's a lot
Right,
to go forward. I
right.
agree with
And,
you.
and there's a lot more foundation to be built,
Hmm. Yep.
unfortunately.
Hmm.
Mm. And in the new book, the one that you and Julian are finishing up, um, what's the foundational piece you're
Well, you'll
working on
you'll
there?
be delighted to hear this. We still espouse the sequenced model of treatment,
Right.
and we call our model the sequence relationally based treatment. So we're keeping that model, but we're also very much expanding it in terms of what techniques are used and also particularly the mind-body connections and incorporating the neuroscience findings and the somatosensory and somatic findings that are brand new or fairly new, and you've been working with that for a long time. And we're also talking about how to plug in where there is an evidence base of a particular technique, where to plug it in when you're working with somebody with complex trauma, because it doesn't seem to work the same for
Right.
both. And that we're getting very strong data that skill building and making someone's life, helping someone make their life more stable and more satisfying is as important as doing the trauma processing in many cases.
Right.
and that there's something that can co-occur in the work, and that even though what Judy Herman set out with the three-phase model is, phase one, two, three, it's a highly flexible model too, and can be moved around and flexed into modules and into what the particular individual is needing, or
Mhm.
what the focus is needing to be.
Right, right. And I think I'm so glad that you're emphasizing phase-oriented treatment because it's there are a lot of critics of
Mhm.
stabilization now.
Mhm. Yes.
Right? Dick Schwartz being the leading
Mhm.
critic of
Yeah.
stabilization,
Mhm.
which is very disturbing to me
Right.
because I think of stabilization as actually the most important phase
Mhm.
because
Right.
because people do have to build a life and they do have to build a way to live in it
Mhm.
because otherwise they process all their memories and then they have no life.
Mhm. Yeah. I agree with you. Well,
Yeah.
I'm very interested in also the research that Bethany Brand is in the middle of doing, which is a randomized control trial, an international trial of some of the more difficult complex trauma and dissociative patients, and showing that the stabilization mechanisms and strategies that they're using have been working with these clients, and there's a decrease in their dysregulation, their destabilization. There is a lot more skill building and understanding why these things are important. It's a slower pace treatment, I think, but they're showing really remarkable effects. So I think we need to be paying attention to that. And, I think we've all come to the point that treatment is eclectic. There are many, many different orientations and things that work, but it helps to have an overall frame to think about it.
Right.
And
Absolutely. It's
yeah.
I mean, I think of it as necessary to
Hmm.
have that overall frame
Hmm.
because otherwise
Hmm.
it, you know, it just could get very chaotic.
And it does get very chaotic,
Right.
and I've appreciated your book on the fragmentation of survivors. We're also I'm just finishing up on this chapter now, talking about working with dissociative clients. That's another area that many of us never got any training in and
Right.
had to learn the hard way. And it's something that's very expectable with this population. So whether it's dissociative processes that they use, or they're switching into different fragments or into different self states, it takes a complicated situation and makes it even more complicated. So
Absolutely.
it helps to have an understanding of that and how to approach that in a client.
Absolutely. And that's another shared soapbox, I'm sure.
Hmm.
We have is again, why why isn't dissociation in that psychopathology course
Hmm.
that everybody has to take?
Well, I'll tell you a good one about that. I had a student in my practice a few years ago who was taking her courses, and she came in one day and she was really very upset and outraged. And she said that her professor had announced that they weren't going to do anything to speak about dissociation, especially dissociative identity disorder, because it did not exist, because he had never seen it. Now, how scientific is that?
I
So she went directly to the dean and the academic dean and complained, and he had to ultimately take back his statement. But that's one of the reasons we don't hear about it, because a lot of people don't believe it.
Right, absolutely. And 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 many people who who may have treated someone with DID without ever knowing it.
Right, right.
Yeah, so it's a much better world in which to be treating trauma because we do know so much more, but
Mhm.
there is much more to do.
Absolutely.
So at least that keeps us out of full retirement.
Yes, it does. Still to be negotiated, right?
Right.
Mm.
I have a feeling it'll be a negotiation I'll be having until I'm twitching and drooling.
Right, right. Well, my business partner, Joan Turkis, is in her 90s and she's still going strong. And I love
Oh,
talking to her because she's still very actively engaged in a lot of things and it's a good role model. Um,
yeah.
and
Yeah.
my family takes bets about what that I'm never going to retire, so why do I even talk about it? So
I know. I know. Uh, I think we come from the same family. Well, Chris, this has been wonderful. Thank you so much for this chance
Mhm.
to talk.
Yeah, we haven't talked in a long time, so
I
this is
know.
wonderful. It
I
was nice to
know.
see you in person at the recent conference.
I know, and I really wanted to see more of you, but somehow I didn't see anybody.
Yeah, yeah, that was a busy conference.
Yes, very, very.
Mhm.
Well, may our paths cross again.
That would be
I
nice.
thank you so much.
Okay, thank you for inviting me. Nice to be with you.